back to T-spot? Or
Yeah, we can do T-spine.
oh.
So I'm just going to show you guys tabletop T and L spine, and then we'll move down to the sacrum coccyx. I'm going to show you guys that today as well. Okay? All right. So let me make sure I am lined up. Okay, maxed out. All right.
Well, we moved the bed. JP moved the bed so you had more room that way, so you could always
Oh, thank you.
move it the other way.
All right. Well, if you guys want to come to the foot of the bed, it might be easier for you to see. So I'm not blocking your point of view. Okay. Just be careful not to be too close because I will be moving him down. So again, you're going to be centered at T7. Okay. Basically, as long as at the top part of the cassette, you're right at the shoulders, you're going to get overlap of the C spine and down to the L spine. Okay, and that's because of beam divergence. I would normally put my marker right here by the shoulder, right under the patient, so it's not sitting on the patient. Oh, I'm gonna bring this up. So, and it's a 40-inch SID. And then you're gonna wanna collimate side to side. Again, you can leave it open a little bit, just, you know, to have latitude in case the patient's spine is curved. But do make sure you're centered appropriately. And please, I don't wanna see this. It's not a chest x-ray. We don't need all that excess anatomy. Okay?
Is there a good way to know where exactly T7 is? Because I feel like I'm usually just estimating. Oh, yeah, okay.
That's one way. It's better for men than women, but some women's breasts hang down, so that's why it's not always a good way to find it. But the xiphoid process, too, right?
Okay.
And that's typically right in the center of the nipple line for most people, but again, some women that are very well endowed, their breasts might hang down lower, or they might be hanging off the side.
Yeah.
I don't know.
Some people are just like kind of overall larger, so it's hard to tell.
Right.
And obviously you get feel for the xiphoid process, like you're not gonna be like.
Right. So, yeah, so basically what I would do if you want something like a visual cue for this, just make sure the top part of your plate is getting a little bit of the C-spine, and then don't collimate top to bottom, make sure it's open.
Okay.
So that's going to be the best way for you, and you're going to naturally be lined up where you need to be.
That's
So that's what I do. Okay? So that's our AP. All right. So I'm going to show you guys the obliques for the thoracic spine in order to get the zygapophyseal joints open. So I'm going to have you turn all the way to a 90-degree angle, or a 90 degree on your side. Okay. So for thoracic spine, this one's super weird. So the angulation for a thoracic oblique is 70 degrees. It's much easier to have your patient roll completely 90 and come back 30 degrees to make the 70, rather than them to come up 70 degrees and hold it. It's much easier for them to lean back a little bit than it is for them to try to hold themselves up, you know, anteriorly. I'll put this sponge behind them so that they have some support. So you're gonna come back, but you have to make sure that they don't come back all the way. They're not coming back to the 45. If you have the sponge under them, it's 45. So if they lay completely flat, that's not good either. But you do want them to come back and have a little bit of room between them and the sponge, and you'll be 30 degrees from the 90, okay, or 70 degrees on their side. For this one, it is going to be the upside that the doctor is looking at. Sorry, I don't want to get you.
You're good.
Okay, because it's an oblique too, you might want to open side to side a little bit more. Make sure you got it. But this is just like the cervical spine. So when you guys are doing the obliques for the cervical spine, the intervertebral foramina that the doctor's looking at, even though it's LPO, they're looking at the right intervertebral foramina. Okay, same thing with the thoracic spine. Even though he's an LPO, it's the right zygapophyseal joints that the doctor's focused on here. Does that make sense for everybody?
So the upside?
Yes.
Okay.
Same thing with your cervical spine. And that's definitely gonna be a test question. And then I would just put my marker, now that his left side is down, I would put my marker by his left shoulder on the board. Okay?
Mister, can you repeat that test question one more time so I can write it down?
So when you're looking at the obliques for the thoracic and cervical spine, it is going to be the upside that the doctor is looking at, not the downside. And then lumbar spine is going to be the downside for those obliques.
You'll go over that in lecture you said, right?
Yeah, and I have it all mapped out in a table,
Sure. Okay.
so you guys will probably just want to memorize that. Okay. So I'm not going to test you guys on positioning for this, but I do want to show you what it looks like. It might be in the handwritten portion, but I'm not going to have you position your patient in the thoracic oblique. Okay? All right, I'm going to take this out, Mike, and then you're going to roll all the way on your side. So I'm going to show you guys the lateral thoracic. It's really important when your patient is going into the lateral. You can bend your knees for stability. Yeah.
What about my arms? Should I have them?
Yeah, they're gonna be in front, like the sleeping position. Yeah, just like that, perfect. But when you guys are going into the lateral thoracic spine, it's really important that you make sure that their under shoulder isn't too far forward. That's a mistake I see a lot of techs even make, is they don't make sure that their patient is completely in a lateral position. So I'm gonna have you bring the shoulder back towards me. Yep, so bring it, this one towards me, don't, yeah, and then I'm gonna move you, yep, perfect. And then you might, once you get this shoulder back towards you, you might need to bring their other shoulder a little bit more back, rotate them back a little bit to make sure that they're nice and straight, and you would just feel their back, make sure that they're nice and straight to the cassette, or perpendicular to the cassette, okay? Again, I'm gonna put my left marker down at the top portion for this picture, and then also make sure that you are more posterior to the patient because that's where your spine is. If you need to open up a little bit, you can, so you see a little bit of light.
Is there
Because
something
the
you would say is a good indicator, like on the ear? Is it something like on the ear or neck that is a good for?
I don't think so.
Okay.
As long as you're, you know, basically you want to be posterior to where the humeral head articulates with the shoulder. You're going to be posterior to that. Okay. But if you're so posterior, you're kind of on the edge of the patient right here, that's way too far, and you're going to end up clipping the thoracic spine that curves forward. Okay? So if you're like right behind where that humeral head articulates, you should be right in the right spot. Okay? All right. Everyone good? I know we're kind of going fast. So now I'm going to show you guys the lateral lumbar spine since he's already in position for it. So what I'm going to have you do, Mike, you're going to bring your knees up to your chest as best as you can. So I'll initially tell patients to get in the sleeping position. Usually they know to bring their arms up in front of them and to bring their knees up. One reason why you want their knees up higher than lower is because it helps straighten their lumbar spine, okay? So you'll see patients are kind of leaning all over. Last year I had a student, she was a really good student, but she came into this problem where during the test, her patient's knees were like kind of bent, they weren't up very high, and she told me, she was like, I know that there's rotation on this, what's going on? And so all I did was tell her patient to bring their knees up, and then it straightened out, and it was like an aha moment for her, okay? So I'm gonna come down to the iliac crest, and again, you're gonna be posterior because that's where the lumbar spine is. And then for this particular one, because it can be hard to get your marker in there, I'll just put it on their hip because I know it's not gonna be in the way of the spine, so the bottom anterior portion of the hip. Okay, it's not gonna obscure anything there. Make sure you got it on there. Okay, actually your iliac crest is a little higher. Sorry, Mike. Again, you're gonna want overlap with T12 in this picture. One other piece, let me see if I can find the lead. Here. Sorry. So when you're doing tabletop lumbar spine, there's a lot of scatter. So when I was a student, because the equipment was old, I'm not sure what you guys do at your clinical sites, it just kind of depends on the equipment. We're usually shooting 90 at 90. It's really hot, but it's because it's a really thick part of anatomy that we're shooting through. So with a higher technique comes more scatter, right? So for us to clean up the scatter, in addition to our plate having a grid, we're gonna put this lead piece right behind the back, okay? I know the ART really likes asking this question, so this will definitely be a test question. And what this does is it cleans up the scatter behind the patient's back. Okay?
Just for the lumbar?
Mm-hmm.
And just for tabletop lumbar?
Yes.
Obviously.
Yes. The reason why we wouldn't do it standing, which it would make a difference standing, is because most lead pieces you're not going to be able to hang off of your plate if they're standing, so this is better if they're supine. Does that make sense for everybody?
Okay, I saw it a lot when I was doing the workbook. I think they'd asked that a lot.
Yeah, I know. And that,
It was like brought up more than once, so I didn't understand what the point was.
yeah, so now you know.
Got it.
Yeah, so it cleans up the scatter and it will make a more crisp image. When you guys have a lab today, I highly recommend you doing 2 lateral L spines so that you can see for yourself. I confirmed with the last class, yes, there was definitely a difference. So I want you guys to see that difference when you have the lead versus no lead behind the patient.
Is it bad if there's any of it in the light field? Like, do you have to be like super cautious about that, or is it okay if there's just like a little?
If there's a little, it's okay, but it is better if you just collimate and you have it like right outside of where the light field is.
Okay.
But if it's in there, it shouldn't make a big
Okay.
difference. But it is better, it's just better practice to have it right outside the shadow.
Okay.
Uh-huh.
And for lateral T-spine, would you do 90 at 90?
No.
Okay.
Yeah, definitely not for T-spine. The L-spine is just, it's a thicker bone.
Okay.
And you don't have so much soft tissue, connected to it, so you don't have as much air. Because remember, the lungs are right in front of the spine, so you have a lot more air in that area than you would with your lumbar spine.
Okay.
Does that make sense?
Mm-hmm.
Okay. I'm gonna show you guys a spot, because now, for every single spot, tabletop, you should be angling 5 degrees caudal, okay? So you angle 5 degrees caudal. You can see Mike's hips are a little forward, tilted up. That's why we would do the angulation caudal. If you get a patient where their hips are angled the other way, I personally have not observed anyone like that, but if you do, then you would flip the angulation the other way, okay? But most people are gonna be angled like how Mike's hips are, and you're gonna need a 5 or 8 degree angulation. Remember, for women with larger hips, it's gonna be 8 degrees. And the average person with, average size hips, it's gonna be 5 degrees. On the book it says male 5 degrees, but I've seen some women with smaller hips, and so I would do 5 for them too.
Men with big hips.
Yeah, well, and same thing, if you see a man with bigger hips, then you would go 8 degrees. So that's totally valid. And then I'm gonna put my hand on his hip, right where the iliac crest is. I'm actually lined up perfect, so I'm just gonna collimate down to my little box. I'm gonna put my marker right here, and then just make sure I have my plate lined up, and that would be my spot. We don't need the entire sacrum and coccyx in this picture. This is more for the articulation of L5S1, okay? And then I would keep my marker on their hip. It should stay nice and straight, and then that way you don't have to worry about it obscuring and getting in the way of the anatomy. Okay, so I'm gonna take my marker. Now I'm gonna show you guys sacrum and coccyx. I'm gonna start off with the lateral since Mike's already in position. For these pictures,